Hello?
Yes,
Request control, please.
yes,
Yes.
I'm requesting. So I have presented with the uh, single image ultrasound study.
Are you sure this single?
Yes, there is multiple, yes, and with color Doppler, B mode and the color Doppler, scrolling. Uh, so I have multiple dilated bowel loops, and there is mild intraperitoneal free fluid, and there is echogenic wall in non-dependent area of the bowel loops.
Excellent.
These lines, it looks like nematodes intestinales.
Okay.
There is another image for focused on the liver. There is multiple cellular echogenic sheets of hyperechogenicity of likely uh, uh, air inside the liver. So it is looks like I will ask the patient about the patient if the patient is premature, less than 32 weeks. Maybe this is necrotizing enterocolitis associated with portal vein gases. And then I will shift the patient to see if there is and review if there is X-ray to see if there is no more proteinuria, and convey this findings to
Leave them out.
the
Leave them
pediatrician
out.
immediately.
What? Leave them.
Uh,
What is your differential diagnosis?
and necrotizing enterocolitis pneumatosis intestinalis.
And what is this?
The portal vein gases.
Okay. Go on.
Uh, If this is the same patient, I have
Yes.
presented with the patient with pipigram, and the nasogastric tube is seen. It is it's tip side hole seen above the gastroesophageal junction. There is a mild granular densities of post chest
Yes.
field, and there is mild bowel dilatation in the normal distributed bowel, but with normal bowel dilatation and less bowel positive gases seen in the pelvis. Um, Here is not definite. There is the pneumoperitoneum, significant pneumoperitoneum or regular signs, no football sign.
Excellent.
So um, I couldn't see also air overlying the liver along the portal vein distribution. So I think it is a pneumatosis and, from previous ultrasound. It is a pneumatosis intestinals,
Yes.
and we convey the finding to the referring physician, pediatrician, immediately.
Okay. Thank you, doctor. Doctor, I have one question. Do you think what is the science? What is the critical science in pneumatosis intestinalis necrotizing? Sorry, what is the critical science of necrotizing enterocolitis? What is the most
You know,
critical?
uh, you mean the wall thickness or necrosis of the wall?
You have necrotizing enterocolitis. What is the most dangerous sign that if you find this patient is in high risk of this? Give me one sign. Only
Portal
one.
vein gas.
No, that is why I ask you.
Mm.
Why? What else? What else?
Bowel
Only one
perforation.
sign. One sign. Only one sign here in the X-ray. What is the most dangerous sign?
Is
Both
it
the
in
patient
this
in high risk of this.
in this X-ray?
No, no, in general. In general.
Okay. I'm not sure.
Pneumoperitoneum, doctor. Very, very simple question.
Okay.
Very simple. Pneumoperitoneum because pneumoperitoneum concerning perforation. And why I ask this question? Why? Because portal vein gas in neonate is not a dangerous sign, my colleague. Leave the mouse, please. Doctor, leave the mouse. My colleague, portal vein gas, this is a portal vein gas. In neonate, يعني has a not bad prognosis. The opposite in adult, portal vein gas is a dangerous sign. That is why I ask him. Okay? In adult, portal vein gas is very bad sign. Why? It is a sign of infarction in adult. Okay? But in neonate, it has not bad prognosis at least. Okay? But if you see a case of necrotizing enterocolitis, you must rule out any signs of pneumoperitoneum. Doctor, could you show me where is exactly here the signs of necrotizing enterocolitis? Use the arrow, please.
I think maybe this is double wall sign or
No, no, no.
aneurysmal.
Where is the signs? Where is the signs of pneumatosis intestinalis here? Okay. Where? Which
And
part of the loop? Show me. Is this loops? This?
here
Which
in the
one?
right lower quadrant.
Excellent. What is
And
this appearance? Mottled appearance.
motor
Yes, mottled appearance. Because really, sometimes we are confusing. The babygram and show us a dilated bowel. It must be necrotizing enterocolitis. But exactly where? This one. Why the mottled gas appearance? This one is specifically. There are here some, but here is very obvious. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Yeah. This
Yes, sir.
baby has distended abdomen.
Okay, sir. Sir, I'm provided with a X-ray abdomen,
Mm.
frontal projection. I can appreciate that there is a dilated multiple small bowel loops which are central, and there's air in the rectum, but the small bowel loops appears to be dilated. And I also see some air which is seen lining the wall. I can appreciate the wall of the small bowel,
Mhm.
somewhat regular sign. And
Mhm.
also, sir, apart from this, I can't. There's some degenerative changes in the spine, sir. Age of the patient,
Age of the patient, he is adult, by the way.
adult. Okay, sir.
Yes.
Okay, sir. Yes, sir. Sir, so I'm suspecting a small bowel obstruction.
Yes.
I want to check the erect view of the chest to look for the air under the diaphragm to confirm my finding about the complication of pneumoperitoneum.
Eh,
Apart
thi-
from this,
This is the only available view.
okay, okay. Only available. Okay, so the small bowel. Apart from this, I found that there is a paucity of a bowel in the right lower zone. Maybe the lead point would be on the right side,
Mm-hmm.
and most of the bowels are small. I don't find much large bowel loops, so I'm suspecting small bowel loop. Apart from that, I want to find any no calcification at the renal or at the gallbladder area. And apart from that, but degenerative changes are in the whole spine. So I will look for the causes of small bowel and will convey my finding to the referring physician about the small bowel obstruction.
Mm-hmm.
So
What else?
apart from this,
There are very critical, very important critical sign here. You must be
okay, sir. Okay, sir. So first of all, the regular sign I'm suspecting there's a air
clear.
outlining the bowel, and also, sir, there's some air lucency in the right lower quadrant,
Where
and flank. So right subhepatic region, I find some air lucency on the right side.
show me by the arrow, please.
Oh, sir, I'm requesting control. Okay, sir. So this area, the right.
Show me.
Okay, sir. Sir, this right margin of the right hepatic margin.
No, no, this is the paracolic fat.
Okay, paraqualified. Then I will, sir, see the air at the falciform ligament. Sometimes air also accumulate at the falciform ligament, but in this case, I don't find much air. And apart from this,
Mhm.
important sign, small bowel. So this air also, the epigastric region air also is there.
No,
This
look at
also,
the edge
okay,
of the bowel. Please look at the edge of the bowel.
edge of the bowel. Yes, sir. Sir, the right iliac fossa, there is an hair.
Mm.
And so some calcific density is there in the right hemipelvis.
Doctor, look this. Is this regular
Yes, sir.
sign or not? Here, this one, very obvious, sharp, pencil-like.
Yes, sir.
So, okay,
Pencil.
so
Yes, sir.
this
Regular
is very
sign.
difficult, by the way. So, there
Okay.
are a bowel dilatation, looks like a small bowel. Why? See,
Yes.
this is a complete fold. Okay, and there are sharp or double wall sign or regular sign here. This one, here, this one. At least this loop is very obvious. So it is
Okay.
a dilated bowel with perforation. What is your next step?
Yes, sir. Sir, I will urgently convey my finding to the referring physician in ER. And if a patient is like, if CT can be arranged after resuscitation of the patient, we look after the status of the patient, and after rehab, rehydration and all this stuff, CT can be provided to look for the cause. But right now, it's an urgent emergency. I would pick up my phone and convey my finding to referring physician and ER physician to
Okay.
resuscitate the patient. Yes,
Thank
sir.
you, doctor, so much. Next candidate.
Yes, Doc.
1 second. What is this? Okay, doctor. This
Okay.
patient, this patient, routine babygram. Tell me.
Okay, this is a frontal radiograph of a mature skeletally patient. It appears to be a neonate. I can see that there is soft tissue lesion here noted within the right side of the abdomen, which cause displacement of the bowel loops, almost of the bowel loop toward the left aspect and the lower aspect of the abdomen. I couldn't see that there is any evidence of intestinal bowel dilatation. I can see that there is evidence of the clips, umbilical clips. So this is a neonatal baby.
Yes.
Also, I'm looking for any tubes, or I can see here this, but I'm not sure about this. This is a tube. I couldn't see it well, but I believe that there is a tube here.
Where?
Uh, this one with its tip,
Where?
but this one, this one,
I
I
tell me because the control is with me. Which anatomical location?
okay. In upper neck,
Okay,
I
excellent.
think in upper.
This is the
Okay,
maximum zooming, by the way. See. Okay, and
okay,
so you
yeah.
are correct. What?
Uh,
Yeah.
um, I believe that this maybe, but this baby is routine. I'm not sure about why this tube is here. Maybe this is a nasogastric tube or endotracheal intubation. I'm not sure about, but I want to have a look for the chest also if there is any abnormal in the chest. Both the lung appearing normal. Maybe there is a slightly enlarged heart size, but the baby is supine, so it's borderline for me.
Okay.
Uh, okay, just I want to look. for any other abnormality. In the vertebra, I can see also that there is abnormal vertebrae here, which may be hemivertebra of the baby.
Correct. So
Okay.
what's
Uh,
your
sorry.
yes, what is your differential?
In my differential diagnosis, this baby has maybe abnormal cardiomegaly and abnormal hemivertebra, and also this tube, which I am not sure about, which may be nasogastric tube, but it couldn't be go to the stomach. So this may be a factoral anomaly of the baby. I need to go for other association. I want to look for the limbs. And also I want to look for any other congenital abnormality
Yes,
for the kidney by ultrasound also, because it could associated with the renal anomaly also.
yes.
I will convey the finding for the referring physician and for ultrasound of this baby, and also for checking the limb X-ray for this baby,
Okay,
and also for anal anomaly. For anal anomaly, because it's sometimes associated with anorectal malformation.
thank you, doctor, so much. Doctor, but do you think what is the type of this fistula?
Could this is esophageal atresia. Uh, uh, This appear to be esophageal atresia, but there is also a gas noted here, so there is a tracheoesophageal fistula.
Okay,
Uh,
okay.
it
Mhm.
could be the type H type or type 5, as I remember. I'm not sure about the number of the type or the.
Each type you must see the catheter go down.
Yeah. And it's less common. So I believe that it is the most common with the esophageal atresia and tracheoesophageal fistula in the distal part.
Okay, so you are telling me there are a distal fistula.
Yes.
Okay, thank you, doctor, so much. Fantastic. By the way, see, doctor, very subtle sign. Very subtle. Doctors, when you have a baby gram, your mind must be programmed. Number one, is this RDS or any lung abnormality? But here the lung looks like generally good. Okay. Number two, about the fistula. 90% of the gastroesophageal fistula presented with this in X-ray, this retained catheter. Number three, at the vertebral column. Number four, what about the abdomen? Is there are any obstruction or necrotizing enterocolitis? So in any baby gram, at most you have 4 or 5 pathology. Number one in the neck, number two in the lung, number three and four, two here, either obstruction, upper or lower GI obstruction, or necrotizing enterocolitis. So you must program your brain when you face this babygram 1, 2, 3, 4, 5. When I see ultrasound, I must think in 1, 2, 3 like this. You will find your Viva more easier. Why? When he give you an abdominal MRI of adult, he, يعني, for example, he want from you something related to adult. This is what I mean. Okay, my colleague. In one Viva, they give us out and in phase sequences. So the pathology almost related to fat. We must program our brain like this. By the way, the pathology is related to the fat. It was bilateral angiomyolipoma, and then the examiner, after discussion, give us some brain like this. Okay, my colleague, this advice every session I am telling you in which pathway I must go through. Thank you, doctor, so much. Next candidate. Next candidate. Hello?
Assalamu alaikum, sir.
Ma'am?
I'm 15. I'm candidate 15.
No, I think
I'm candidate 13, so 14.
Okay, that's fine.
yes, we skip one. We skip one candidate. Dr. Nagam?
Number 9. Yes, 9 is not responding. So now we are
10?
14.
Yeah, 10 is done.
Okay.
14 right now.
Okay. 14. 14 is
Yes.
ready.
Yes.
Okay. Doctor, this is 1 second. Show. A neonate presented with abdominal distension. Go on.
I'm provided with a AP abdominal film in a skeletally immature patient. Here I'm able to see that there is dilatation of the bowel loops, predominantly involving the small bowel, seen along the left upper quadrant as well as the central abdomen. I'm not able to see the rectal shadow. Neither am I able to see the large bowel loops, which are the large bowel loops are not opacified. The large bowel loops are not air filled. I'm seeing that there is a um, there is gross dilatation seen in the right upper quadrant.
Okay.
I'm not able to see any evidence of free air within this phlegm
Yes.
to suggest a pneumoperitoneum. Mm, So I think it's predominantly the small bowel which is dilated, but I'm not able to see the distal loops again of the small bowel.
So, what is the next step?
So I would want to do. Are there any more images, sir, or is it just this one image?
This one only.
Okay, then my next step would be. I don't think ultrasound would be of any use here. The next step would be to go ahead with the CT abdomen contrast.
Okay.
Okay, I'm provided with barium series over here, where I'm able to see that the colon. Okay, this is looking like the large bowel. This is outlined with contrast right from the distally. If I'm going, I'm able to see the rectum, the sigmoid colon, descending transverse, ascending colon, right up to the cecum. And this looks like a double contrast examination, and I'm able to see that there are few filling defects that are seen along the ascending colon. Also, I'm seeing that the caliber of the colon looks reduced, predominantly along the descending colon as well as the sigmoid colon, uh, and the rectum appears normal. So I'm thinking if this could be a microcolon.
Yes. Hello?
Yes, yes. Am I audible?
Yes, yes, go on.
Yeah, so I'm thinking if this could be a microcolon. So the possibility here could be I would like to correlate, check with the clinician if there is any history of meconium passage soon after birth.
Yeah. So, what's your concern?
I would want to rule out whether it could also be a meconium ileus or a microcolon. So I would like to differentiate between these two. And if the patient has not passed meconium, I'm not really sure about the next, how do I go about this next, but I'm just concerned whether it could be a microcolon or it could be a meconium ileus.
What is the difference between both of them?
In case of meconium ileus, the newborn would have, no, I'm not sure. I don't think I'm sure of what I'm saying.
See, look at the whole colon. Is the whole colon small in caliber or part and the other is normal?
It's predominantly the transverse, the descending, and the sigmoid colon. Ascending colon looks comparatively normal in caliber.
Okay. So, see here. See here. Where is the end of the contrast here? At what?
I'm seeing it up to the cecum, and I'm not able to, yeah, the
Okay.
cecum and
So
probably.
what happened here? What happened here? The contrast didn't go beyond this. What
Yes.
here? What do you expect here?
So ileocecal valve.
This is the ileocecal valve, by the way. And okay. But the contrast stopped here.
In the
Didn't
cecum.
didn't go beyond the cecum. So what happened at this level? What happened? See, again, you inject the contrast, and the
Yeah.
contrast go, and almost all this colon at the same caliber. And then the contrast stopped here, and they can't go through at all, within the ileum. So what happened at the ileum? This is the appendix, by the way. The
Okay.
appendix. This is the cecum. So what happened for the ileum?
Ileal atresia.
Okay, ileal atresia. Why? Thank you, doctor, so much. What happened to my colleagues? In this X-ray, there are bowel dilatation. It may be lower or lower GI obstruction or upper GI. Really, we don't know. And if you told the examiner, doctor, there are a bowel obstruction, and you give all possible, no problem. You can ask, doctor, what is the history? Almost the examiner will give you the correct history. He will told you vomiting. So you must tell him, doctor, I have a doubt of upper GI obstruction. Either the examiner will guide you, doctor, the patient or the baby didn't pass meconium. So he guiding you towards the lower GI obstruction. Okay, my colleague?
Yes. Yes.
Then we will ask why? Why? Because if it is upper GI obstruction, especially very high obstruction, the next examination should be barium fall through or barium male. Okay? But
Yes.
if it is lower GI obstruction, we should give barium enema or
Yes.
contrast enema, to be 100% accurate. What happened here? They gave enema, and the enema stopped here abruptly, complete stop. Somebody will tell me, doctor, I know this is a bowel. No, this is appendix. This is appendix. So the ileum is completely occluded. So it is ileal atresia. Somebody will tell me, doctor, but I can see bullet-like filling defect here. Why doesn't it be like meconium, meconium plug, meconium alias? No, my colleague, this is normal. You should see some meconium inside the large bowel. This is the meconium in the baby is like the stool in adult. So it is not a big deal to see some meconium here. But where is the cache? The cache is here. The problem is here. Okay? So it is
Yes.
ileal atresia. Thank you, doctor, so much.
Thank you, doctor.
And it. By the way, to be fair, even me, because all of us not familiar with this contrast, for the first time, our answer is not the best one. Why? Because in our routine practice and our daily work, we didn't do a lot of bariums or contrast. So don't worry, my colleagues, today. Just after I finish, listen to the record well, and really it is very easy. Don't worry. My colleague requests the control.
Assalamu alaikum, sir.
Request control.
Yes, sir. So this is CT chest.
Okay.
Sir, I'm trying to scroll.
1 second. 1 second. Use the arrow. Use the arrow.
Yeah, sir, it's not moving.
1 second. 1 second. 1 second. You can catch this.
Sir, thank you. Sir, Yeah, it wasn't moving before. Yeah, sir, please can you do it? It's not moving.
Okay, go on.
Sorry. So this is CT chest mediastinal window axial view. So can you please tell the history?
Okay. 25-year-old female with chest coughing, productive cough.
Okay. So this is 25-year-old female with cough. Okay. So this is mediastinal window, which is showing lymphadenopathy in the precarinal and subcarinal regions. There are no pleural effusions on the mediastinal window, and there is significant lymphadenopathy in the pre-aortic region, and spleen is prominent. It's not that enlarged. Um, and there is some calcification seen in the porta hepatis. Um, okay, so sir, can I see the lung window, please?
Lung window. Okay, this is lung window.
Okay, so this is axial CT lung window showing bronchiectasis in the
Yes.
bilateral lung fields.
Yeah.
Can I see the apical segments here? So there is bronchiectasis more on the right, but it is bilateral and then extending up to the bases. So, and there is some yeah, there is some interstitial thickening as well. So this looks like a case of cystic fibrosis
Okay.
with the bronchiectasis and some uh, and there was lymphadenopathy also in the mediastinal and pre-aortic regions. Um,
Okay. What else?
sir, please go down.
Okay. What's your other differential diagnosis?
Sir, cystic fibrosis, and there is acute infective changes. There is some ground glass haze and central lobular nodules.
Okay. What else?
Uh, axial window ahead lymphedema. Sir, I'm trying to. Uh,
Look here, please.
yes, sir.
Leave the mouse. Leave.
Okay, sorry.
What happened here?
So there's cholelithiasis. So there is cholecystectomy. So these are cholecystectomy clips.
What else?
Uh, the spleen is enlarged. Vessels appear prominent. There is some so collateral formation.
What else? Can you detect, doctor? Can you detect
Yes.
the pancreas?
Oh
Where is
no. Oh, pancreatic atrophy. Yeah, yes, sir. Yes, there is pancreatic
not
atrophy.
just atrophy?
Yes,
What is
sir.
the name of this process in cystic
So this is
fibrosis?
fatty replacement of the pancreas.
Yeah, this is
Yes.
very common. My colleague in 2 years ago, in one of FRCR exam, it was a long case. What happened? What happened? It was, I think, 10-year-old, and the liver was completely cirrhotic. Okay, the liver was cirrhotic, and hypertension, and many signs of liver cirrhosis. And what else? The pancreas show fatty infiltration or fatty replacement. Okay, and it was mainly abdominal CT and a little bit bronchiectatic changes. Okay, so in a child with liver cirrhosis, with portal hypertension like this, not a big deal. Liver cirrhosis and pancreatic fatty replacement sink in cystic fibrosis until proof otherwise. Okay, here, that is why I start by abdomen, because I am very kind examiner. Other examiner, what they will do, they will give you this one only, abdomen, okay? And you must pick up this. If you pick up this and there are fatty replacement in young age, you must ask for chest. You will see this bronchiectatic changes, cystic fibrosis, almost predominantly apical, Okay. And you can at this moment make a diagnosis of cystic fibrosis. Doctor, could you tell me what is the underlying pathology of cystic fibrosis?
So there is deficiency of the enzymes with which can degrade the secretions.
No.
So there is
No, you are correct. It is a secretion related, but not related to enzymes.
sir, it's a some transferase.
Yes. No, transferase. No. Sodium potassium pump abnormality.
Oh yeah, okay, yes.
What happened? Sodium potassium pump abnormality result in sick secretion. This sick secretion يعني occlude all any lumens. Occlude here the bronchi and result in bronchiectatic changes. Occlude
Yes.
here the pancreatic duct and cause pancreatic insufficiency and replacement, and even in the liver. In cystic fibrosis, what is your next step or management plan? Could you describe?
Sir, the patient will be referred to uh, cystic fibrosis, so pulmonology, and sir, the final
What
treatment
else?
is transplant.
See, what else? What is other association?
And sir, associations. Okay, so sir, cystic fibrosis has gastrointestinal manifestations as well.
What else?
Um,
What about the infertility?
yes, sir, infertility as well. Yeah,
Yeah, it's very important.
yes, sir.
Because I just told you it has a sick secretion. So any secretory system will be affected. Okay?
Yes,
Thank you, doctor, so much.
yes, sir. Yes, sir.
Uh,
Thank you, sir.
Nagam, we finished the list of today. Hello?
Yes, we did.
We did?
Yes,
Yeah. So, see, my colleagues,
finished.
I will take the coordinator. This is the right because they waste a lot of time. Dr. Nagam, are you ready? Hello?
Yes, sir, I am. Thank you so much. Yes, thank you so much. Yes, so any history?
One second, I will share again. Okay, Dr. Nagam, this is failure to pass meconium. Go on.
Okay, so I'm presented with the frontal radiograph of the abdomen of a neonate with failure to pass meconium. I can see that there are multiple dilated bowel loops, no air in the rectum. I couldn't appreciate any free air within the peritoneal cavity, distal NG tube in place. The visualized osseous structure shows normal vertebrae, pelvic bones, and proximal femurs. Concerned about bowel obstruction. In such age group, I would suspect meconium ileus, meconium plug, atresia of the distal small bowel. So I would like to go for lower GI contrast study, please. So this is the lower GI contrast study. It shows opacification of the sigmoid, the rectum sigmoid, and the colon, as well as the distal ileum.
Okay.
I couldn't identify filling defect to suggest meconium ileus or microcolon. So the small bowel is, distal small bowel is visualized. So maybe it is small bowel like jejunal atresia.
Yes.
So I would like to look for other views if available, please.
This is the only one.
Well, so my concern is small bowel atresia, maybe at the level of the jejunum.
No. See. This is the rectum. This is sigmoid ascending. Then transverse. Then descending. This, see here, this is a small bowel here. All of this is small bowel. Okay?
Okay.
This. Why? This here is the what is cecum here.
Cecum.
Yes. So all of these are small bowel. What happened here? Look at the diameter here and here and compare. Compare the diameter.
Okay, so it is smaller. Distally, it's getting smaller.
Yes.
Okay, yes, with multiple large filling defects. I just saw them. Multiple large filling defect along the whole descending colon.
Yes.
So these could be representing mucus plugging.
Yes. Thank you so
It
much.
is
So your final diagnosis?
okay. Thank you so much.
What is your final diagnosis?
Meconius plug.
Yes.
Meconius plug. Barium. This study could be diagnostic as well as therapeutic.
Yes, thank you. By the way, my colleagues, this is a not ideal case of barium plug, meconium plug. This is not ideal. But what happened here? The patient has a clinically not passing meconium, and everything is opened, and no ganglionic segment. Okay, the diameter here, just here, يعني just smaller than here, but this is not a big deal. What is the most striking abnormality? This is this filling defects here, and I think here. But look here. So the only logic diagnosis here is a meconium plug. But usually in the exam, they will give you a very clear case. The clear case show very small diameter of especially the descending colon and the normal diameters of transverse and this ascending filled with these plugs. Okay. Thank you, doctor, so much. Um, our coordinator, Dr. Amiga, are
Thank
you?
you, Doctor.
Thank you. Dr. Amiga, are you here online?
Yeah,
Dr. Amiga,
good evening, Dr. Ravi.
good evening.
Yes, yes.
Yes.
Yes, Dr. Rami.
Yes.
Yes,
Welcome.
good evening.
Good evening. 15-year-old male patient with poor urinary stream. This is the control film. And this one.
Okay. I'm provided with CT urography images of a 15 years old male patient with the poor urinary stream. In the excretory phase, I noticed that the contrast is seen outlining the urinary bladder and the distal ureter, and the urinary bladder appears to have multiple trabeculations and is giving appearance of Christmas tree.
Yes.
So this is most likely this is in keeping with the neurogenic bladder, uh, and there is also dilatation of the bilateral ureters noted. In my routine practice, I would like to see the kidneys also, since this may be associated with psychoureteric reflux. So I noticed that the left ureter is dilated in its whole extent, with the contrast noted in the pelvic glacial system. Reflux of the contrast noted in the pelvic glacial system with ballooning of chelicus. So this is a grade 5 reflux. I'm looking at the bones in my routine practice. I would also look at the vertebral bodies to look for any spinal dystrophism. Uh, so I would like to zoom up the image a bit to look for. I think there is a defect noted at the level of S1.
Excellent.
S1 vertebral body. I do not see it. Spinous process at the level of S1 probably. So there is a defect at the level of S1 vertebral body.
So what's your
And
diagnosis?
so this is a spinal dystrophism with neurogenic bladder leading to the psychoureteric reflux.
What is the name of this bladder?
Neurogenic bladder Christmas tree appearance.
Excellent. What is Christmas tree? Multiple divertically
Yes.
and looks like peak-like. Okay,
Yes.
pyramidal-like. Thank you, doctor, so much. See, my
Thank
colleague, this is a defect here. Okay, when you see this appearance, you have only three differential: either posterior urethral valve, either primary reflex, or neurogenic bladder. My advice for all of you, first, look at the bladder. See, multiple, innumerable diverticuli. So exclude primary reflux. Either you dealing with posterior cerebral valve or you are dealing with Christmas tree of neurogenic bladder. Next, look at the bone. There are defect. This is a neurogenic bladder. So in two step, I think here also in L5 there are, I think, another spinal pivot here. At least this, not like this. So in two step, we diagnose it. Okay, my colleague? Okay. If it is a posterior urethral valve, the examiner must give you lateral and urethra. Must. This is a must. And he should show you the urethra. Thank you so much, doctor. Dr. Anagam, I think there are still few candidates who wanted to participate.
Yes, sure. There are a lot of them.
Yeah, can we take 10-minute rest and we will continue again, my colleagues?
Sure.
Okay.
Okay, thank you so much.
Okay, bye. I will come after 10 minutes. Welcome again, my colleague. Let's take about 5 candidates. Hello? Hello?
Yes, sir.
Yeah.
I'm here. Candidate 19.
Candidate 19. Is this
Okay.
the last? I think this one. Okay. Go on, doctor. No history.
Okay, sure. I have here X-ray of baby gram. I'm
Yes.
able to make out the gas shadows over, especially at the right hemi-abdomen, and the right iliac fossa appears mottled in appearance. Mm, However, no, uh, no, no, no portal venous gas, no football sign, no, no regular sign.
Okay. What else? Hello?
There is sorry, there is normal air in the stomach.
Doctor, do you remember the map that I just gave to you, the mind map that I just described for all of you in any babygram? Please tell me about it. Enumerate when you is presented with a babygram. 1, 2, 3, 4. 4 things. And tell me from up to down.
Sorry. Okay, again, sorry. So firstly, about the lines, able to see likely a feeding tube that is malposition.
Yes.
It's going
See?
up.
خلاص خلاص, you get it. You get it. Do you remember?
Sorry.
I told you, look at the neck, look
Yeah.
at the chest, look at the abdomen. The abdomen, two things you should exclude: either obstruction, whatever the type of obstruction, either necrotizing enterocolitis. I think 99% of the pathology of the babygram will within this mind map. So tell me, what is this?
Oh, so it's a malposition feeding tube. Is going upwards.
Hmm.
Back into the oropharynx. So it's a malposition. Malposition Rouse tube.
Yes, the tube here. What is this location? Anatomical location.
Throat, trachea.
Not trachea. This is a nasogastric tube. So,
So
hmm,
it's at the area of the epiglottis.
no, the nasogastric tube from the mouth to, not to trachea, to something.
I think it went through, is going through the nose, and then it go upwards back to the stomach, back to the oropharynx.
See, the tube here in the esophagus. Why it is stopped here and go up again? What happened in the esophagus?
Oh, there's a atresia, sorry. There's a
Yes,
esophageal
atresia.
atresia.
Okay. Look, distal. There are or there not gastric air bubble.
There is gastric air bubble in the stomach.
So this atresia associated with fistula or not associated with fistula?
I think not associated with fistula.
From where this air came?
Oh,
From where? So it is associated with fistula.
oh, okay.
So this is gastroesophageal atresia with fistula. Okay.
With
So it is not
fistula.
type 1 or 5 because it is, if it is 5, it should come down. It is between 2, 3, 4, like this, at least.
Okay.
But if it also it is, I think it is not 2. See here, my colleague, I think I bring the type of atresia here to revise.
Okay.
This is not the type
Oh,
of atresia.
polyposis.
So at least if you told the examiner this is a gastroesophageal atresia with fistula, with with a tracheoesophageal fistula, okay, he will accept. If
I
you
see.
know the type, he will be very happy. What is the type do you think here?
Say not so sure about that. Sorry, sir. But
No problem. We are discussing. No problem. What is the type? Type 1. Type 1 has no fistula. Okay, so this is not type 1. Okay. Okay, my colleague. Type 5 has H shape, and so it must go down. So it is not type 1 or type 5. Okay. It is between either other types. What is the other types? Do you know?
the type, we go by type C. Is it type A, B, C, D?
Okay, type B has proximal fistula, so you will not see gastric air bubble in type B or 2. So it is either C, D or 3, 4. Okay?
Okay.
Why?
C.
Because these types only have distal gastroesophageal fistula. Okay, thank you so much. Also,
Thank
here
you.
you must rule out other signs of victoral as the vertebral column, heart, or other regression, or imperforate anus, anal atresia, all of this. And if you see the limb, sometimes they bring the forearm, and there are radial ray anomaly. Okay, so take care from each pixel of the X-ray. Thank you, doctor, so much. Next candidate.
Thank you.
Yes, doctor.
Welcome. 6-week male patient presented with high bilirubin.
All right, I'm presented with ultrasound grayscale images of abdomen of a 6 weeks old baby. Here I can see liver is of normal parenchyma. There is fluid I can see. I think that is the right pleural effusion.
What else?
The Doppler studies.
Don't worry about the Doppler.
Okay. I want to see the portal vein and biliary system. I could not see any intrahepatic biliary duct dilatation.
What you are worried about in this patient? What you are
I'm
searching
worried
for?
about any underlying biliary atresia as patient
Okay.
has a history of hyperbilirubinemia. So I will see the gallbladder and will also
Could you
look at
find the
the.
gallbladder?
No, I cannot find the gallbladder,
Okay.
and I want to see the
What is
biliary
this?
duct.
What is this echogenic line?
This echogenic line could represent the triangular cord sign of the
Excellent.
biliary atresia.
What is your next step?
Next, I will convey the findings to referring clinician and will advise nuclear scintigraphy HIDA scan for confirmation.
This is Haida scan. 1 second.
All right, so there is uptake of in the liver, and I cannot see any excretion in the
Excellent.
bowel in
Excellent.
the
What is this?
69
What
minute
is
image.
this?
This is bladder.
Excellent. Brilliant. But
So I
here,
can,
1 second. My colleague, the bowel, you must see here. This is the bladder.
yeah,
You must see here any excretion. Follow, 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 follow. Nothing. Okay.
yeah, 69 minutes. So I will like to see a study at 24 hours. If there is no
This is
excretion at
24
24
hours.
hours,
20.
yeah, so it will confirm the diagnosis of biliary atresia. I will convey the findings to referring clinician and will advise MDT discussion, and it needs a surgical procedure
Thank
for
you, doctor.
correction,
Thank
most
you, doctor.
likely a Kasai procedure. Thank you.
Thank you so much, doctor. Really brilliant. My colleagues, if there are any excretion to the bowel, you will see the bowel here. Serpentinous tubular structure here. Not like this is the liver, this is the spleen. But the bowel, I will show you later one normal HIDA scan. But at least this is very common. Do you do you know, my colleagues? We have been presented twice with this HIDA scan in the exam within 1 year, two times. Very important and very easy. Okay, thank you, doctor. Biliary atresia. See, my colleague here, the most striking abnormality is absence of gallbladder. And it is this echogenic triangular cord sign is it borderline, but you can tell the examiner, I suspect this is a sign in absence of the gallbladder and in correlation with the clinical picture. Next candidate. Hello,
Hello.
35-year-old female patient, asymptomatic, just routine follow-up. What is this?
So these are ultrasound images of a 45 years old female,
Okay.
and I can see hypoechoic area,
Yes. What is this?
multiple hyperechoic lesions in the liver.
Okay.
So, considering the multiplicity and age of the patient, these could represent metastatic lesions.
Okay. What else? But the patient
And
is asymptomatic. And look here, no mass effect. This is vein, biliary tract, completely not infiltrated or compressed by the mass. Here also, here. So it is a benign looking.
okay,
What is your differential? Multiple echogenic.
so these could be multiple hemangiomas.
Okay, what else? But see here, multiple variable shape, bizarre shape. See, no definite shape for them. Really, you can't tell me this is doctor rounded oval, bizarre shape.
Yeah,
What is your next step?
CT,
This is a CT, static image. I think what is this?
static image.
MRI. Static image of this MRI. What is this?
So these could be biliary cystadenomas.
Excellent. Cystadenomas? No. Biliary cystadenomas with these numbers? Not accepted. Okay. What else? See, multiple,
So,
innumerable, bizarre shape. This is the most important buzzword, bizarre shape.
okay, this can be Caroli's disease with
No. Where central dot sign? Never. What else? By the way, you are very correct. You are in the correct pathway. What else? See, post contrast, there are enhanced nodule here. Here it is this one, but after magnification, this one. Give me another differential diagnosis.
uh,
Biliary hammer.
hamartomas. Okay, biliary
Yes.
hamartomas. Yeah.
Biliary hamartomas is bizarre shape, multiple variable size with no definite shape. And you may find this enhancing nodule inside it, not connected to the biliary tract. Okay? You can put metastasis in the differential. Multiple hepatic abscesses. Okay, but clinically the patient is asymptomatic. So
Okay.
never exclude metastasis and abscesses. Okay? Thank you, doctor, so much. The most important buzzword in biliary hamartoma is bizarre shape. Okay, my colleague. Next candidate.
I think
Hello?
we can take anyone from the attendance right now.
Okay, anyone want to try? I think one candidate text me, she is October and wanted to take a chance. يعني I don't know the name, but she texted me today. Anyone wanted to take a chance?
Yes, I'm available.
Who? Hello?
Hello, I'm available if
Yes,
there's no
yes,
one else.
yes. Female patient routine checkup or pre-operative checkup.
Okay,
What's
thank you.
what's your opinion here? What you tell me?
Okay, so this is an axial non-contrast enhanced CT scan of the abdomen in a female patient presenting for routine checkup. I can see that the liver density is diffusely increased, and then it appears somewhat coarse, and then there's splenomegaly.
Excellent.
Unfortunately, I'm unable to scroll. If you can scroll, thank you very much. So, looking at that gallbladder, it appears somewhat distended. I'm seeing the innumerable hypodense, ovoid, fairly
Excellent.
oval-shaped lesions
Excellent.
distributed within the liver parenchyma.
Yes.
So, to take this further, I would recommend.
What happened here?
Okay, yes. So there it appears somewhat tubular and cystic.
Yes. What is this?
Yes, I can see the central dot within it,
Excellent.
which could be vascular.
Excellent.
So,
And see. What is this? Follow it, please.
okay.
What is this?
Yes, that.
What is this? Hmm.
Oh, yes, I see that. So those are collaterals, multiple dilated collaterals, and that was the portal vein. So that
Yes.
may indicate that there is portal hypertension.
Okay, give me a professional diagnosis, please.
I'm making an impression of now I'm thinking of Caroli's disease.
Okay.
And
Complicated
then
by
complicated by portal hypertension
and liver
and liver cirrhosis.
cirrhosis.
Yeah.
Okay, look here. See, is it communicating with the biliary radical or not?
It's communicating with the biliary
And
radicals.
this is a differential point with biliary hamartomas. Very important. Thank you, doctor.
Okay.
Doctor, could you tell me which type the coronal disease from a biliary cyst? Type 1, 2, 3, 4, 5, like this. Which type?
It's type 5.
Excellent. Do you know the other types, doctor?
I have an idea. I
Give-
just remember that type 3 is a diverticulum, or
Okay.
was it type 2?
Thank you, doctor. I will explain it now. See, my colleagues, see what happened here? Multiple innumerable cysts with central dot sign. Doctor, I can't detect it. Scroll and at least you will pick some. See? Central, central, and it is looks like communicating with biliary tract. Doctor, I didn't know how to pick up the communication. Okay, very easy. Go to the hilum. Okay? This is the portal. So anterior to the portal is the CBD. Follow this. So this is tracks of intrabiliary tracts. Follow it. See. Follow. These tracks dilated, forming the Caroli disease or Caroli cyst with central dot sign. Okay, when you see these collaterals and the splenomegaly, you must think about liver cirrhosis. Despite the border is uneven and this is not the healthy parenchyma, يعني you can another signs of portal hepatic cirrhosis. So it is a Caroli disease complicated by liver cirrhosis, and portal hypertension. Thank you, doctor, so much. I think
Thank
this is the different type of biliary cysts. This is the normal. Number one is fusiform dilatation. Number two, eccentric. Number three is cell herniation of into the ampulla of Vater. Number four, intrahepatic biliary reticle cyst and extrahepatic. Number five, only intra with central dot site. Very important, my colleagues. This is very important. Okay. Do we have another candidate? Hello, Dr. Nagam?
Yes, anyone of the attendants, please, would like to participate?
Hello, can I
Yes,
participate?
yes, sure, sure. 37-year-old female patient with non-specific abdominal pain.
You will scroll for me.
Yes. What happened?
Okay, there is thickening of the greater, these are contrast and CT axial sections of the abdomen.
Okay.
A 55-year-old patient with the routine, I think, and I can appreciate that there is a slightly low density of the hepatic parenchyma. Intrahepatic biliary channels are mildly dilated, and the stomach is contrast filled, and I can
No,
appreciate
see,
that there is.
see. You start here well. Follow it. Follow. What happened? What happened? What
Okay, there
happened?
is, yeah. Okay, there is dilatation of the intra and extrahepatic
Excellent.
biliary
Okay.
channels, and I can see
Okay.
that there are calcified. There is
Excellent.
multiple chunky areas of calcifications involving the.
Doctor, 1 second. You are speaking with the examiner. You find a pathology here, and then you follow it and you describe it. So tell the examiner, doctor, I have a doubt about it, and give him any provisional diagnosis. Okay? And then shift to the other pathology. What's your concern about this biliary dilatation? Hmm?
So
Biliary.
there might be some pathology in the distal end of the CBD.
Look at the distal end. Where is the distal end?
Okay,
See, the distal end must be here, by the way. What is this?
there are chunky foci of calcifications.
Related to
Uh,
whom? See, before you tell anything, related to the CBD or the pancreas?
these are in the
Hmm. See,
yes.
this is the CBD, the calcification outside the CBD. Hmm.
Uh, these are related to the pancreas, the uncinate
Okay,
process of the.
okay. So what's your diagnosis?
So there might be some, I can put differentials in this case. It could be due to some mass in the pancreatic uncinate process, or it could be due to calcification in the pancreas, which could be sequel of chronic pancreatitis.
Okay, 1 second. Chronic pancreatitis is correct. Look here. What happened for whole the biliary system?
There is marked dilatation of the intra and extrahepatic biliary channels,
If I told
and there
you
is
there are no obstruction here, no obstruction, what is your differential diagnosis?
there could be some stricture because I can see leaking at the distal end of the CBD.
The end of CBD is normal. Don't worry about it. See, look here. Look here. No, see here. That is it's entry in the duodenum here. I think this one. Okay, the distal end is normal. What is your other
Okay, then
differential?
okay, then it could be some congenital anomaly
Yes,
showing
like
a dilatation of the intra and extrahepatic biliary channels, Carol's disease,
what is the congenital anomaly, please?
choledochal cyst, type of choledochal
Excellent,
cyst.
excellent. So you give a variety of differential, okay? Especially look here inside the liver. Look, do you think the biliary tract here at the periphery is dilated? Here. See, better to look here. See, only the CBD dilated and the markedly dilated, and almost the central, and then see, look here. Can you detect any biliary dilatation at the periphery or يعني beyond the central?
These are the dilated channels are in the center of the
Yes,
liver.
yes. This is see my colleague. See, follow this one. This. See, follow this one. Nearly the central biliary tract is dilated, and this is normal. Okay, this is normal. So there are no obstruction. This is non-obstructed dilatation. This is the point of differentiation, by the way. Marked, marked, marked dilatation of the CBD and the central biliary reticle without obstructing stone or masses, and then not associated with a peripheral. Overall, the periphery looks like normal. So, both on your differentiation is a coloidal cyst. This is a coloidal cyst. Thank you, doctor, so much. I think we cover a lot of
Sorry,
the. Yes.
I need to ask a question. Sorry, regarding this case, I was suspecting some abnormality along the greater curvature of the stomach. It was projectional, I thought. On the CT, when I was looking at the CT sections.
Where is it? By the way, this is the
Okay, these were
greater.
these were okay. These are
This is the
related to
greater.
contrast.
Okay.
Yeah,
This. I think this food.
yeah. This
Okay.
is related to vegetable.
Okay.
And the chunky mucus are due to chronic
Chronic
pancreatitis.
Chronic pancreatitis. Yes. Cause the calcification. Okay. Thank you for all of you, my colleagues. Thank you, Dr. Nagam. Thank you, Dr. Mega. I think we cover a lot of the anomalies, pediatric or other or adult age cases of the GIT. Revise this record again. Tomorrow we will start at 12 sharply, hopefully. Thank you for your attendance. Thank you again, Dr. Nagam, and special thanks for our great doctor, Dr. Nahla, for this access and this support. Thank you, my colleague. Goodbye.
Thank you, doctor.
Bye.
Okay, goodbye. Thank you.